speaker for the day is Dr. Tan Chih Kiang. She'll be talking on doubling my chances in curing triple-negative breast cancer. Dr. Tan is a consultant clinical oncologist at Picasso Hospital, Malaysia, with a strong commitment to improving cancer care. He holds an MBBS and a Master's in Clinical Oncology from University Malaya. As the Honorary Secretary of the Malaysian Oncological Society, Dr. Tan works closely with peers to advance oncology education and research. He has contributed as a co-author to international clinical guidelines and participated in numerous clinical trials, taking on roles as both the principal investigator and sub-investigator. He also provides his expertise as an external reviewer for international medical journals. Dr. Tan played a key role in establishing stereotactic radiosurgery services in East Malaysia, where he treated the first SRS patient in Malaysia, in Sarawak, His clinical interests span gastrointestinal cancers with a focus on liver cancer, as well as breast, gastrointestinal, and head and neck cancer. Dr. Tan.
Thank you. Thank you, Chairperson. So I'll be talking about doubling my chances of curing triple-negative breast cancer. Right? Okay. So my outline of my talk for this afternoon will be on a bit of data on the breast cancer scenario in Malaysia, and then subsequently, just for an introduction for those who are not very familiar, I will talk about a bit of like subtypes of breast cancer, so you roughly know what I will be talking about, because I'll be focusing on just one of the subtypes today, which is the triple-negative breast cancer. And then subsequently, we will talk about the management of triple-negative breast cancer and how we actually can double the chances of curing the patient with early triple-negative breast cancer. So I think if you look at the breast cancer scenario in Malaysia, this is based on our latest National Cancer Registry, published just a couple of months ago, but it is from the year 2017 to 2021. As you can see here, between the last registry to the recent one, there is definitely an increase in terms of the number of incidents in terms of breast cancer. Even though breast cancer, they still remain the top commonest cancer, right? But you can see that compared to the previous registry over the last 2012 to 2016, I think the 2017 to 2021 showed that the prevalence for the breast cancer has actually increased as well. Okay, so if you look here, right, generally we think, or what we used to say that, cancer is an elderly disease, right? So for breast cancer, most of the time, I think the commonest age group that present with breast cancer will be those in the 50s or 60s and higher. But I think over the years, for the doctors who are actually managing breast cancer, we do agree and we do see more and more younger patients actually coming in with breast cancer. Particularly for triple-negative, because I think it has been shown to be associated with hereditary genes. That means that BRCA genes, if let's say for those who are aware. So normally this group of patients, sometimes they present as early as even in their 20s. Right? And unfortunately, I think like most cancer in Malaysia, most of the cancer, patients, when they present to us and being diagnosed with cancer, most of the time they are at the later stage. For breast cancer, I think all of you probably will agree with me, is that I think the awareness for breast cancers are actually not lacking in Malaysia. Every year, I think once you reach October, you can see everywhere is pink in color, right? In the newspaper, in buildings, even in hotels, they are offering certain buffet or high tea, with the theme regards to the breast cancer awareness. So I think the awareness is definitely not lacking. But I think despite that, as you can see here in Malaysia, what it shows is that about 50% of the patients, when they are diagnosed with breast cancer, they still come in at stage 3, stage 4, right? So when they come in at stage 3, stage 4 itself, actually already put them at a very disadvantaged condition where their outcome will definitely not be as good as someone coming in at stage 1 or stage 2, right? So, but despite the awareness that we are able to generate, I think about half of them still coming in late stage. For some other cancers, which has even lesser awareness, for example, lung or liver, it can be as close as 80–90% of the patients actually coming with later stage. So just to share a bit about subtype of breast cancer, right? So generally there are a lot of subtypes, but I will divide them into 3 main categories. So the first one will be the hormone receptor positive subtype. So as you can see in the diagram here, what happens is that you imagine that one is actually a cancer cells. So on the surface of cancer cells, there's actually presence of this receptor. So ER stands for estrogen receptor and PR stands for progesterone receptors. So because of this presence of receptors, right, so we call it a hormone receptors, subtype of breast cancer. So why do we need to actually subdivide them into different subtypes? Is because the management in terms of the drugs that we are going to offer the patient will be different as well. Right? But this is not our topic today because we'll be focusing on triple negative breast cancer. Okay. So like I mentioned earlier, for those patients with hormone positive, one of the treatment that we use to treat them is actually hormonal therapy, because the hormone therapy then can bind to these receptors, right, to help to either control the disease or reduce the risk of recurrence or cure the patients. Another subtype is actually HER2 positive subtype. So actually there are HER2 presence on breast cancer cells. It's just that in the HER2 positive subgroup or subtype of patients, this HER2 actually amplified. That means actually more copies of this HER2, right? So when they actually have this amplified HER2 presence on the cells, we call them a HER2 positive subtype. And for this group of patients, we don't use hormonal, right? We actually offer them a targeted therapy called an anti-HER2 targeted therapy. So as you can see, different subtype drugs that we use to manage them can be completely different, okay? And finally, the last one which I will be focusing on this afternoon, it will be on triple negative breast cancer. So triple negative, as its name showed, basically they are negative for estrogen receptors, negative for progesterone receptors, and negative for HER2 as well. So in this group of patients, you are actually not able to offer them any of the hormonal therapy or targeted therapy. So a bit on triple negative. So incidence of triple negative in Malaysia actually ranges somewhere between 12 to 17%. So roughly it's about 15% of all breast cancer patients. Right? And like what I showed you earlier, they are not suitable to use a hormonal therapy or anti-HER2 targeted therapy to treat them because of the non-existence of any of the receptors and non-HER2 as well. So hence, because of that, generally they tend to have poorer prognosis and higher mortality compared to the other subtype cancer. So as you can see here in the table, I'm not sure if you can appreciate on the right side. Okay. So what they show on the upper curve there is that showing you different subtype. As you can see, triple negative is one of the lower graph, meaning that generally they actually do poorer. As you can see, for the Kaplan-Meier curve on the bottom one, right? So compared to the other breast cancer subtypes, when they have triple negative breast cancer, generally they have higher chance of recurrence compared to the others as well. So all these are telling you that, generally patients with triple negative, they tend to do poorer compared to the other subtypes. So how do we actually treat or manage triple negative breast cancer patient? So of course, one of the criteria that we actually look at, it will be the stage. So depends on the stage, we will treat them actually differently. So I will divide them into early triple negative breast cancer stage, which is generally your stage 1, 2, and 3, because the treatment are still curative in intent. Whereas the other one will be the advanced, where the treatments are not for curative, but more to control the disease and prolong patient survival. So because today we are talking about doubling our chances of curing, so I'll be just focusing on the early stage triple negative breast cancer. So as you can see, early stage triple negative cancer, what we used to do a couple of years ago, not too long ago, or even today itself, is being still practiced in some centers, is that when a patient presents with early stage triple negative breast cancer, they will undergo surgery first. And once the report comes out, then the doctors will then offer them either chemotherapy, because they are not suitable for hormonal therapy and they are not suitable for anti-HER2 targeted therapy, because these are triple negative. So normally we only give them chemotherapy. But what is the problem? So the issue here is that if you see, after they have the surgery, we only have one chance actually of curing the patient by offering them this chemotherapy in the hope that after the chemotherapy, they don't recur, right? But the effectiveness of this chemotherapy that we are offering the patient are unknown. Because imagine patient actually had already surgery, the tumor has been removed, right? So how are you going to assess the treatment that you're offering the patient, whether it's going to work or not? Because there's nothing for you to compare with. There's no baseline, right? So you actually basically do not know, and you just offered them based on evidence. But whether it's actually suitable for this particular patient, how well it will work, no one knows, okay? And because of that, we tend to see higher recurrence in this group of patients. So what we do nowadays is that for most early triple negative breast cancer patients, we do a slightly different approach, where we actually offer them neoadjuvant systemic therapy. So neoadjuvant means something that we give them before their definitive treatment. So definitive treatment in this case will be the surgery. So we actually offer the patient some form of treatment before the surgery. And why we actually wanted to do that is because by doing that, there are a few advantages. Number one, right, we tend to have more optimal surgery, and patient tends to be able to achieve complete response. Complete response meaning that when they actually, after have the treatment, when they do surgery, when they examine the specimen or the breast sample or the tumors, there's actually no more cancer cells left. So by actually giving the patient some form of systemic therapy, right, more than half of the patient actually will have complete response, meaning the tumor disappeared completely. So by achieving that, actually it itself already helps to reduce the risk of the cancer recurring. But what I want to talk about further is that besides the benefit of the surgery as well as response, one thing we are able to achieve now is that we are able to test the effectiveness of this drug that we're giving, because the tumor is still there, right? So you give the treatment and then followed by surgery. And when you examine the surgical specimen later on, you will be able to tell how effective the treatment that you actually have given to the patients. And actually give us a second chance of curing the patient, where if let's say the response is very good, you can then actually give them back the same treatment, or you can actually de-escalate the treatment, meaning that we can actually give lesser things. You don't have to do so much of treatment for the patient because they have a very good response to the treatment that we have offered. But for those who did not respond very well, right, you actually give us a second chance to give them something else to try to improve our chance of curing the patient. Okay, so why we are offering the patient neoadjuvant? So basically it's based on one of the studies, which is the Keynote 522. So what they do here is that you actually give the patient 8 cycles of chemo together with immunotherapy before the surgery, right? So what they found from the study is that they actually increase the chances for pathological complete response. About for up to 2/3 of the patient will have complete pathological response. And besides that, they actually did show that at 5 years, lesser patients actually have recurrence. And recently, they also published the overall survival, meaning that by giving them the neoadjuvant treatment with an immunotherapy like pembrolizumab, what happened was that besides higher chance of response, lower chance of recurrence, you are actually curing more people because people survive back longer compared to the typical method or the one without the immunotherapy. And hence, neoadjuvant immunotherapy plus chemotherapy has become the standard for most of the early triple-negative breast cancer patients. So after surgery, like I mentioned, there are always 2 possibilities, right? One is that there's a pathological complete response, meaning the tumor completely disappeared. So in this patient, because the response is good, so all you need is just to offer the patient some form of radiotherapy, maybe continue with the immunotherapy, and hence you don't have to do much more. But on the other hand, for those patients who responded, but there are still some cancer cells or tumor left behind, residual disease, they did not achieve complete response. So what you do is that because you wanted to increase your chance of curing the patient, you tend to do more and by escalating the treatment. So besides the immunotherapy and radiotherapy, you can actually offer the patient chemotherapy or even targeted therapy. And this has been shown in studies that they actually can make the patients increase their chance of curing. So the 2 studies that I would like to quote will be on the chemotherapy and targeted therapy. So regard to the targeted therapy will be the Olympia study. So what here it shows is that patients who had a BRCA gene, which is a BRCA carrier, once they had some form of treatment before surgery, and when after the surgery, if let's say there's still residual disease, that means no complete response, by giving them an additional 1 year of target therapy, they actually tends to do better. So as you can see in the results here is that you can see a nice separation of the curve, right? That those patients who had this 1 year of targeted therapy, they tend to live longer, as well at the same time, they have a lower risk of disease recurrence. Another one will be the CREATE-X study. So this one is using chemotherapy, similar concept where patient had some form of treatment before surgery, and after surgery, when they have the residual disease, then you actually offer them chemotherapy with this drug called capecitabine. So and again, you can see a nice separation here. What it shows is that patients who had no complete response after initial treatment before the surgery, by giving them additional capecitabine for 6 to 8 cycles, they are able to reduce further the risk of the recurrence. So to summarize today is that I think women with early triple-negative breast cancer have more hopes than ever, right? Because with better and more personalized treatment before and after the surgery. And neoadjuvant systemic therapy, particularly with immunotherapy, has given higher response, lower recurrence, and better survival for this group of patients. And finally, I think this approach allows us post-surgery to actually individualize the treatment for the patient based on the response by either escalating or de-escalating the treatment, and with more beneficial personalized therapy available for patients. Hence, they actually has increased their chances of curing their triple negative breast cancer. So I think with that, I'll thank you.